This is an archive of the Thirdhand Smoke Resource Center's webinar hosted on April 15th, 2020, entitled Thirdhand Smoke, What Every Healthcare Provider Needs to Know. The webinar consists of a packed hour and a half of presentations as well as question and answers. If you have additional questions after viewing the webinar, please visit the center website for more information. Or if you have questions that remained unanswered, email the center directly. On behalf of myself, Heather Whitfleet, Associate Director of the Center, as well as the rest of our core team, including Dr. Georg Matt, Director of the Center, Dr. Rachel Record, the other Associate Director of the Center, and Lydia Greiner, the Center Coordinator, we thank you for watching. Before we go to the recording, let me tell you just a little bit about the Thirdhand Smoke Resource Center. The center is part of the California Thirdhand Smoke Research Consortium, which is funded by the Tobacco-Related Disease Research Program. The consortium is a multi-institutional and interdisciplinary collaboration involving research groups from Lawrence Berkeley National Laboratory, San Diego State University, University of California Riverside, University of California San Francisco, and the University of Southern California. The role of the center is to disseminate the consortium's research findings and also to spread general information about thirdhand smoke to specific stakeholders and the general public. And with that, let's go to the recording.
So we all appreciate you getting on today in the midst of what we know is a very stressful and really intense time for many of us working in the public health space. And so we wanted to quickly address why we should continue to care about thirdhand smoke during the COVID crisis. And so just a few quick points that we wanted to highlight, which is that at the moment, young people are spending far greater time in environments that we know are likely to have higher levels of thirdhand smoke, which includes the homes of smokers and multi-unit housing. So instead of being at safer environments like schools, they're remaining in environments that are likely to have higher exposure to thirdhand smoke. Tobacco consumption may also be rising at this time, and home smoking bans may be laxed during this period because of increased stress, putting non-smokers at greater risk of exposure. And the health conditions that are related to tobacco smoke seem to be, and evidence is continuing to emerge, linked to greater morbidity and mortality from COVID-19. So again, just increasingly important that we get out these messages about the need for smoking cessation and protection from exposure to tobacco smoke among non-smokers. We have a few learning objectives today, and this is kind of one of our main goals today is to make sure that we are transitioning these learning objectives. So do we want to discuss known and suspected health effects of thirdhand smoke? We want to identify factors that increase the risk of exposure to thirdhand smoke. We are going to describe the behaviors that will lead to increasing smoke-free home environments, and also discuss public health and policy implications of smoke-free healthcare environments. We're going to cover a lot of ground today, and I'm sure you're going to have many questions. We have a link right here and in multiple places throughout this presentation to our FAQ page on our website, where many of the questions you may have may also be answered, and where we are going to continue to post answers to questions that we receive here today. So quick overview of what we're going to do over the next hour and 27 minutes. We're going to have 3 presentations. The first is going to be on thirdhand smoke, what it is and why we should care, by Dr. Georg Matt, who is a professor in psychology in the College of Health Sciences at San Diego State University. Our second presentation will be from Melinda Mahabee-Gittens, and she'll be speaking about thirdhand smoke and the patient encounter. And our third presentation will be from Thomas Northrup, Thirdhand Smoke and the Environment of Care. I'll tell you a little bit more about our speakers before they give their presentations. And then we're going to have a rapid thirdhand smoke Mythbuster session where our various presenters are going to discuss some common myths and responses to them. And then finally, we'll take general questions and answers. So I see a question already in our chat, and I'll answer it right now in terms of our webinar logistics. So each of our presentations is going to last about 15 minutes, followed by 5 minutes of questions and answers. Participants can send their questions to the speakers through the Q&A application in Zoom, and then the moderator, who is myself, will pose these questions to the speakers. Please indicate your name and your organization when posting your questions. And if we run out of time, we promise that we will send out post-webinar communications with the answers to those other questions. And again, you can always refer to our FAQ page. The webinar is recorded. It is going to be archived and posted on the Thirdhand Smoke Resource Center website. So you can go later and access all of this content. All registered participants will be sent the link to this. Notably, the webinar has been approved for 1.75 CMEs, or continuing medical education units. So you can see our post-webinar email for more details about this, and it just requires that you complete the final surveys and pay a small fee. So we again welcome you here today. We're all very excited to have you here. We have a really strong turnout of attendees. We are nearly at 100 participants at this point. So thank you all for coming and appreciating this important topic. Our first speaker today will be Dr. Georg Matt. Dr. Matt is a professor of psychology in the College of Sciences at San Diego State University, and he's also the director of the Thirdhand Smoke Resource Center, as I've mentioned. His research focuses on human exposure to tobacco smoke toxicants in real-world field settings and on strategies to protect non-smokers from the exposure to tobacco smoke toxicants from secondhand smoke and thirdhand smoke. And so Dr. Georg will be speaking to us more about what thirdhand smoke is and why we should care. So, Georg, you can share your slides with us at this point.
Great, Heather. Just a second. Here we go. Can you see the slides?
Yes, we can. You can go into presenter view if that's
Excellent.
possible.
Here we go. Good morning or good day, good afternoon, everybody. I will give you a brief introduction describing where thirdhand smoke comes from, where exactly thirdhand smoke can be found, what chemical constituents are in thirdhand smoke, and how one gets exposed to thirdhand smoke. To understand the nature of thirdhand smoke and how to prevent and remediate it, it is critical to understand that secondhand smoke is the precursor of thirdhand smoke. Secondhand smoke, of course, is the consequence of burning and smoldering tobacco plant material, various additives in the tobacco product, as well as the tobacco paper. Now, different from active smoking, the vast majority of secondhand smoke is actually the result of smoldering side stream smoke. That is the smoke that is being emitted from the tip of the cigarette in between puffs. The reason why this is important is because side stream smoke is significantly more toxic than the inhaled mainstream smoke, primarily because it occurs and is generated at lower temperatures, and that causes incomplete combustion. Secondhand smoke is a really complex mixture of 6,000 and more chemical compounds that have very different chemical as well as physical properties. Secondhand smoke travels very quickly through a room, an entire home, neighboring apartments, because of the properties of these volatile chemicals as well as the ultrafine and fine particles that are part of the smoke. Secondhand smoke can penetrate upholstery because of its small size and its mobility, get into closets, into walls, cupboards. It finds its way behind bookshelves, into drawers, utility ducts. There is not really any space that is safe from secondhand smoke. Secondhand smoke remains in the air from a few minutes to a few hours, depending on ventilation and air exchanges. And there is a point when it appears that secondhand smoke has gone. We can no longer see it, we can no longer smell it. But the question is it really all gone? So here's an illustration of some of these secondhand smoke chemicals. Here we have a smoldering cigarette. The secondhand smoke that spreads around really quickly is composed of a myriad of different gases, volatile organic compounds. Some of these names I'm sure you're familiar with: formaldehyde, carbon monoxide, benzene, and then of course nicotine. There's a group of toxic chemicals, carcinogens associated with tobacco smoke known as tobacco-specific nitrosamines. Polycyclic aromatic hydrocarbons are part of it. A second critical part are these fine and ultra-fine particles, tiny little droplets and solids that, because of their size, float in the air and are easily distributed across an indoor space together with the volatile compounds. And there's a third important constituent known as semi-volatile organic compounds. What makes these semi-volatiles interesting is that they can exist in both gas phase as gases as well as particulates. And as a matter of fact, they exist in an equilibrium where they change rapidly and constantly from gas phase to this droplet particulate phase. As secondhand smoke spreads, it is within seconds transformed into third-hand smoke. And this transformation involves secondhand smoke gases that stick to surfaces and that are soaked up by materials. Very similar to water is being soaked up by a dry sponge. Secondhand smoke particles deposit and accumulate as settled house dust on surfaces, on floors. Over a period of time, secondhand smoke gases and particles become embedded in materials. And interestingly, they're not just resting there. They undergo a process known as chemical aging, where further chemical reactions occur that change these secondhand smoke compounds into novel compounds. Some of those are not found in freshly emitted smoke, but are unique to third-hand smoke. In addition to chemicals, this aging process can also create novel ultrafine particles that can be generated and re-emitted from third-hand smoke. I want to introduce you to apartment.
Can I interrupt you for just
yes, please.
Sorry, you're presenting in a mode that shows it's not the presentation mode, so the slides are very small. Can you try again to click into?
Has this changed now?
Yes, now you're perfect. Thank you.
Okay, that's interesting. Okay, I'm sorry for that. Okay, we're back in apartment 605. This apartment has all kind of interesting objects and personalities. There's a cat, there's a baby, there are toys, there's a carpet, there's a couch, a table, there's a pacifier. Now, as tobacco smoke enters such a space, either because somebody smokes inside or because the tobacco smoke comes in from the outside, it spreads quickly around. As we know, that secondhand smoke over time deposits and adsorbs to the various objects, whether it's upholstery or floors, furniture. The secondhand smoke constituents adhere to and stick to these objects. Over time, these constituents become embedded. If it is a long period of time and heavy smoking, one may see discoloration occurring. And as the tobacco smoke, the secondhand smoke disappears And what's left behind then is this third-hand smoke. So this is the first important property here of third-hand smoke. Third-hand smoke remains. From these reservoirs, third-hand smoke volatile and semi-volatile compounds can be re-emitted. The particles can be resuspended back in the air from these reservoirs, whether it's toys or carpets or upholstery. The particles can be resuspended. And when to this mixture we now add oxidants that one finds in indoor environments from gas stoves, for instance, or from traffic or industrial pollution, novel secondary compounds can be created that were not present in the freshly emitted smoke. So this leads me to my definition of third-hand smoke. Third-hand smoke is a complex, very dynamic, persistent, and toxic mixture of tobacco smoke pollutants. Complex because it is made up of these constituents that have many different properties. Dynamic because it changes over time. Persistent because it can stick around for years. And toxic because of the chemical properties of these constituents. And our definition, we've tried to make it memorable, and our memory aid here is the 4 R's. Third-hand smoke remains on surfaces and dust embedded in objects. It can be re-emitted back into the gas phase from these reservoirs. It can be resuspended from the accumulated fine and ultrafine dust, and it reacts with oxidants and other compounds in the environment to create these secondary and tertiary pollutants. Third-hand smoke persists and changes over time. As tobacco use continues, indoor environments can become saturated. As I mentioned before, literally like that dried out sponge that soaks up water, these indoor environments, upholstery, carpets, walls, can become saturated with third-hand smoke constituents. Third-hand smoke remains embedded in materials, and we found in our research heavily polluted environments 5, 6, 8 years after heavy smokers stopped or moved out. And in the absence of any secondhand smoke, non-smokers are unknowingly and involuntarily exposed to these re-emitted and resuspended third-hand smoke components. I want to show you some pictures just to get some visual aids, and I'm sure you can relate to many of these pictures because you've seen them yourself. Here is an apartment of a heavy smoker who moved out, and you can see the discoloration. And if you look closer, you may actually have a memory of the odor of stale tobacco smoke emitting. Here are some plates that were in a cupboard where tobacco smoke infiltrated and stayed behind as third-hand smoke. Here is a third-hand smoke residue that was wiped away from a wall. Here is a piece of furniture, and you can imagine that third-hand smoke not only resides on the outside, but penetrates deeply into the upholstery of a piece of furniture. Of course, toys have similar properties, and toys become polluted. Here is a young woman who has noticed that third-hand smoke also stays behind on a smoker or on someone living with a smoker because it adheres to clothes, to hair, to skin. Here we have a picture where somebody wiped off third-hand smoke residue. Here is what a dentist might see. And if you've been a smoker before, or if you know a smoker, I'm sure you've seen that there is residue on the hands and fingers of smokers. This is third-hand smoke as well. Third-hand smoke is found in virtually every place that has high human turnover and occupancy. So in the research that we've done through the California Third-Hand Smoke Research Consortium, here in San Diego, we found third-hand smoke in homes of many non-smokers, for instance, who moved into apartments of smokers, non-smokers who quit smoking, non-smokers who live in multi-unit housing where smoking policies might be violated, homes of non-smokers with furniture and other household items that were once used by smokers. Third-hand smoke is found in places with or without smoking bans, because smoking bans were introduced at one point after smoking was permitted. So we find it in homes with young children with smoking bans, in rental cars that were presumably a smoking ban applied, in used cars for sale by a smoker, in hotel rooms designated for smokers and a non-smoker might be asked to stay in. We find third-hand smoke in places with smoking bans, like hotels with non-smoking rooms, but that allow smoking in other rooms. We found casinos after a smoking ban was implemented. In non-smoking movie theaters, where smokers brought third-hand smoke into the non-smoking menu. And as you'll learn from the other presenters, we find third-hand smoke in neonatal intensive care units visited by smokers, as well as in pediatric emergency departments. The toxic constituents of third-hand smoke, you already saw some of the compounds. By mass and by abundance, nicotine is probably one of the prominent ones. But nicotine is also important because it undergoes this chemical aging process and can transform into substantially more toxic compounds, namely tobacco-specific nitrosamines. But as you go through this list, you may recognize some well-known carcinogens, developmental toxicants, various irritants. And at the very bottom, I want to remind you as well that it is not just the chemical properties of these constituents that can cause a health risk, but it can just be the size of the fine and ultrafine particulates that can be extremely harmful to anybody with a pre-existing respiratory condition or cardiovascular condition. Among the adverse health effects, and you'll learn more about this from Dr. Mahabee-Gittens, we know now that exposure to third-hand smoke is genotoxic. It induces DNA strand breaks, oxidative DNA damage, and can cause the formation of DNA adducts. It has also been shown that it causes metabolomic changes in reproductive cells, and in animal studies, we found that it affects the immune system, body mass, liver function, as well as wound healing in mice. How does one get exposed to third-hand smoke? Well, I think based on the previous slides, it makes a lot of sense that exposure to third-hand smoke does not only involve inhalation, and this is a big difference to secondhand smoke. Secondhand smoke exposure is inhalation exposure. Third-hand smoke exposure can be inhalation of these re-emitted volatile and semi-volatile compounds, but it also involves ingestion, especially in children. It's a concern where there is a lot of ingestion of non-food object, a lot of hand-to-mouth contact. We also understand now that third-hand smoke exposure takes place through dermal uptake, as well as through the exposure route through mucous membranes, whether it's through the eyes or nose or the mouth. And the exposure involves pollutants that are in the air, that accumulate in the dust, that are attached to and reside on surfaces, and that are embedded in objects. And just as my last slide, I want to show you a graph that appeared in a recent publication by the Gentner group at Yale University, where they examined third-hand smoke emissions in a non-smoking movie theater. And what you see here in this graph is the estimated exposure in secondhand smoke equivalents from different compounds that were measured. So this was a movie theater that was attended by smokers and non-smokers. It turned out that the smokers brought into this movie theater a whole host of volatile and semi-volatile organic compounds that you see listed along the x-axis. On the y-axis, you see the estimated exposure as a function of a 1 hour exposure in this movie theater. So this 1 hour movie exposure is equivalent to 10 to the amount of naphthalene emitted from 10 cigarettes. The smoke emitted, secondhand smoke emitted from 10 cigarettes. That's for naphthalene. For benzene, about 8. For styrene, about 6, and so on. So the amount of exposure can be substantial depending on the environment. And in this case, the exposure route was inhalation. But in addition to inhalation, and perhaps in home environments with children, more prominent, there will also be ingestion as well as dermal uptake. And this is my last slide, and I invite you to ask questions through the webinar chat option. Thank you very much.
Thank you, Georg. So we have a couple minutes for questions. We had 2 that came up already. So first one was just, could you explain briefly what are DNA adducts and how does that play a role? Georg, can you hear me? Georg, you're muted.
DNA adducts are changes to the DNA as a consequence of environmental and other stresses that interfere with repair mechanisms and interfere with the expression of DNA information.
Okay, and a second question, can you just address briefly kind of differences in product type and most notably what the contribution of e-cigarettes are to third-hand smoke?
So in electronic cigarettes, as we know, we have no combustion of plant material, but we have the emission of volatile compounds as well as of particulates. So to the extent that e-cigarettes contain nicotine, we have semi-volatile nicotine compounds, we have the aging of nicotine, we have the adsorption of nicotine to materials. Many of the electronic cigarettes have various fragrances involved, and depending on the electronic cigarette device, the temperature in electronic cigarettes can reach levels that induce secondary reactions and further chemical processes that can create additional toxic materials. So the electronic cigarette emissions share a subset of constituents, but they clearly do not include a large component that involve combustion products from plant materials. So we found in our research elevated levels of nicotine in homes of electronic cigarette users. Another complication is, of course, that many electronic cigarette users are dual users. So they may use cigarettes outside the home, but electronic cigarettes in the home. If they do so, they bring combustion third-hand smoke products with them on their clothes and on their body into the home. And we have a buildup of third-hand smoke from multiple sources, electronic and combustion cigarettes in a home.
Okay, and I'm going to take one final question right now. Well, there's two different themes that are out there right now. One is a question, again, about the role of cannabis smoke and whether it has harmful properties. Another question is on mitigation attempts. We're gonna push the mitigation question to a little bit later in the webinar and come back to that. But can you just speak really briefly about the contribution of cannabis and the harmful properties of that?
So cannabis is another interesting material. Cannabis, of course, does not have the nicotine, but it has THC and a variety of other cannabinoids, but it involves plant material. And so it has all the combustion-related toxicants from plant materials, including particulate matter in the respirable range, including fine particulates. So there is a lot of interesting research going on right now, but because it involves burning and smoldering of plant materials, it generates this cluster of polycyclic aromatic hydrocarbons, many of which are known to be to cause cancer in humans, and it involves, of course, particulate matter that's being generated. So we expect third-hand smoke accumulations from cannabis. It will show a different mixture of chemicals, but there will be a subset related to plant material combustion that will be shared between tobacco smoking and cannabis smoking environments.
Okay, thank you very much. There's a number more questions, and I promise you we will come back to those questions. But for now, we're going to continue to move on to our next presenter. So I'm going to, excuse me, just one moment here. I'm going to share my screen again. All right, so our next speaker is Dr. Melinda Mahabee-Gittens. She is a professor of pediatrics at Cincinnati Children's Hospital Medical Center and the College of Medicine at the University of Cincinnati. Her research focuses on examining child exposure to tobacco smoke toxicants in the clinical and home setting, and on implementing strategies to educate parents about the effects of tobacco smoke on their children and to help parents quit smoking as a way to protect children from exposure to tobacco smoke toxicants. So thank you, Dr. Mahabee-Gittens, for joining us, and you may go ahead and start.
Okay, thank you. Thanks to all of you for joining in, and I'm ready for my next slide. Okay. Thank you. So today we're going to be talking about third-hand smoke in the context of second-hand smoke and active smoking, and known and suspected health effects of third-hand smoke, limitations of home smoking bans, policy recommendations relevant to third-hand smoke, and how to integrate third-hand smoke into clinical practice. Next slide, please. So as Georg just mentioned, secondhand smoke exposure occurs through inhalation of tobacco smoke pollutants while tobacco is being smoked and continues for minutes to hours after tobacco is smoked. Third-hand smoke, on the other hand, poses health risks independent of and separate from secondhand smoke, since third-hand smoke exposure occurs even if tobacco is not smoked around the child or adult, and occurs not only through inhalation, but also through ingestion and dermal transfer of tobacco smoke toxicants that are stored in indoor reservoirs where tobacco has been smoked before. Thus, third-hand smoke exposure results in independent and cumulative health risks. Next slide. Third-hand smoke exposure is especially concerning in children for a number of reasons. So, although smoking rates have declined, using NHANES data from 2013 to 2014, we know that 38% of children aged 3 to 11 years old are still exposed to secondhand smoke and third-hand smoke. Infants and young children spend a lot of time indoors, which increases their exposure. Additionally, dust ingestion rates are 2 times that of adults, which increases exposure rates in children. Infants and young children may be 100 times more sensitive than adults to pollutants and dust. Specifically, factors that increase children's risk are their anatomy. They have smaller body masses, their physiology, they breathe faster, their behavior, they put everything in their mouth, and their increased adult skin-to-skin contact with their caregivers. Next slide. On this slide, we see the known health effects of secondhand smoke, which includes adverse effects on the brain, ear, nose, and throat areas, the lungs, cardiovascular system, and many other regions. It also results in neurobehavioral effects, increased healthcare utilization, more severe illnesses such as more severe asthma exacerbation and other respiratory illnesses, and academic issues in children as well. It is thought that all of these effects and probably much more are likely associated with third-hand smoke, given the long-term, lasting, and cumulative effects, plus the added exposure to carcinogenic pollutants in third-hand smoke. Next slide. Liang et al. Conducted a study of over 60,000 non-smoking adolescents in Hong Kong, in which they assessed secondhand smoke and third-hand smoke by self-report and the presence of respiratory symptoms, which were defined as cough or sputum production for 3 consecutive months. They found a linear relationship between respiratory symptoms and increased secondhand smoke and third-hand smoke in the home. They also found that exposure to more sources yielded stronger associations with respiratory symptoms. Next slide. In assessing the known or suspected health effects of third-hand smoke, it's best to use biomarkers of third-hand smoke and second-hand smoke, which include cotinine, which is a major metabolite of nicotine and is commonly used to assess exposure. It's a biomarker of second-hand smoke and third-hand smoke exposure in non-smokers and smokers, and it is found in saliva, urine, blood, hair, and nails. Nicotine is a marker of third-hand smoke pollution in the environment. It is found on the fingers of adult non-smokers and smokers, and it's also found on the hands of children who are non-smokers. Next slide. We enrolled a small sample of 25 children whose parents were smokers. We collected hand nicotine on these children, and we found that 100% of them had detectable hand nicotine. Hand nicotine levels were extraordinarily high. They ranged as high as 2,190 nanograms per wipe. And of note, the child that had that was only 2 years old. The geometric mean was 90 nanograms per wipe, and the median was 97.2 nanograms per wipe. Compared to previous research, these levels were 3 times higher than the levels of non-smoking adults living with smokers who had nicotine levels assessed from their fingers. Next slide. We subsequently examined 100 children of smokers who presented to our pediatric emergency department or urgent care at Cincinnati Children's Hospital. We obtained hand nicotine samples on all children and examined their past medical histories, their chief complaints, and discharge diagnoses. We found higher hand nicotine levels in children who presented with chief complaints of cough and congestion, compared to children who did not present with those chief complaints. We also found higher hand nicotine levels in children who had past medical histories or diagnoses of asthma or bronchiolitis. Next slide. In this same sample of 104 children, we found that children who were 2 to 4 years old had the highest hand nicotine levels, followed by children who were 5 to 9 years old, then children who were 10 to 15 years old. Children 0 to 1 years old had the lowest levels. As you can see from the bottom of the slide, there were no differences, however, in hand nicotine levels by child sex, race, ethnicity, insurance type, or income level. Next slide. On this slide, we see that hand nicotine levels increased when the primary caregiver smoked more cigarettes per day. So in the caregivers who smoked 6 to 14 cigarettes or 15 to 40 cigarettes. We also see that hand nicotine levels increased when more cigarettes were smoked around the child, with the highest levels being 15 to 57 cigarettes. But if you notice, there was still a progressive increase with the number of cigarettes. And then also when more cigarettes were smoked in the home. So again, higher levels in children who had lived in homes where 6 to 14 cigarettes or 15 to 40 cigarettes were smoked. However, it didn't show up on this slide, but if you notice on the part that says around child all locations, even children who had no cigarettes smoked around them, they still had hand nicotine levels with GO mean levels of 82.3 per wipe in those children where 0 cigarettes were smoked around them. And then of those children who had 0 cigarettes smoked in the home, their geometric mean was 59.7 nanograms per wipe. Next slide, please. So an important question is, are home smoking bans enough? The answer is no, as we can see on the graph, which again emphasizes what I showed on the previous slide, that children who live in homes where no cigarettes were smoked inside still had nicotine on their hands. So home smoking bans aren't enough because third-hand smoke residue on children's hands increases with indoor smoking, but lack of indoor smoking is not a safeguard against third-hand smoke exposure. Third-hand smoke exposure is more widespread than previously thought, and levels may be associated with clinical illness. Next slide. The U.S. Preventive Services Task Force, Healthy People 2020, and the U.S. Department of Health and Human Services strongly advocate for clinicians to ask all adults about smokers and for clinicians to prescribe FDA-approved cessation medications, for providers to connect smokers to appropriate behavioral interventions, and for pediatricians to ask about tobacco use in parents and in their pediatric patients, and to ask about tobacco smoke exposure as part of routine care. Next slide, please. The U.S. Public Health Service guidelines recommend that clinicians routinely deliver a brief 5-step intervention called the 5 A's, which says to ask about tobacco use at every visit, advise all tobacco users to quit, assess their readiness to make a quit attempt, assist the patient in their quit attempts, and arrange follow-up contact and care to support their quitting efforts. It's important to know that advice to quit from physicians improves adult cessation rates, and adding brief counseling improves rates even more. In fact, minimal interventions lasting less than 3 minutes increases the overall tobacco use abstinence rates. Thus, every tobacco user should be offered at least a minimal intervention, whether or not he or she is referred to an intensive intervention. There are a number of free resources that smokers should be referred to, which includes the National Tobacco Quit Line. You can call 1-800-QUIT-NOW, and you will be connected to a quit line operator in your state. Most states now also offer online enrollment, and so the smoker can go ahead and enroll, put in their information online, and then the quit line operator will call the patient back at a convenient time for the patient. Other options that are free include smokefree.gov, which offers web-based, text-based with smoke-free text, and online chat-based services. There are also mobile apps available on smokefree.gov and on other sites and other social media related resources as well. Next slide. There are a number of pharmacotherapy options to help smokers quit. Over-the-counter options include the nicotine patch, the nicotine gum, and nicotine lozenge. These can also be prescribed, and then insurance will cover them. Prescription medications include the Nicotrol inhaler and the nicotine nasal spray. Additionally, Zyban, Wellbutrin, and Chantix or varenicline are also medications to help with cessation. There are age restrictions on the purchase of over-the-counter medicines, but physicians can prescribe for children who are under age 18. Next slide. Now I will discuss how to integrate information on third-hand smoke into clinical practice. First off, always let your patients know that there is no safe level of exposure to tobacco smoke. Research by Dremer et al. Indicates that 88% of parental smokers believe that third-hand smoke can hurt children, which opens the door to productive discussions that clinicians can have. Smokers need to know that third-hand smoke toxicants can remain in drywall, insulation, and other building materials, and that smoking in another room using a fan or smoking in front of an open window does not prevent third-hand smoke, and that quitting is the only way to keep their child and family safe. Next slide. The CEASE program is used in primary care settings to train pediatric staff how to address secondhand smoke and third-hand smoke with parents. It's used to provide cessation counseling and resources to families. They added what they call the cessation imperative, which is used as part of the CEASE program to include third-hand smoke counseling. Using this messaging, parents are told that all household smokers must quit smoking completely, and that smoking, even when not around children, can expose others to third-hand smoke in the home, car, on the skin, hair, and clothing. And they recommend that this information and messaging is presented early and often. It can be easy to incorporate third-hand smoke messaging into pediatric visits because most parents see their child's pediatrician more often than they see their own primary care doctor. And increases in the number of visits where smoking is addressed will increase parents' willingness to quit and reduce their child's exposure. There are encouraging results from the CEASE program. They found that parents who believe that third-hand smoke is harmful are more likely to protect their children from exposure by adopting strictly enforced smoke-free home and car rules, which is a start. They also found that parents who changed their third-hand smoke beliefs from not believing that third-hand smoke is harmful at baseline to later believing that third-hand smoke is harmful were more likely to try to quit smoking. In Cincinnati, we see very high rates of smoking in parents who bring their children to the emergency department and urgent care. We see rates as high as almost 1 in 2 parents smoke, and sometimes these rates are even higher in the primary care setting at our hospital as well. And many of parents are very resistant to quitting, and they're not necessarily happy when I talk to them about the dangers of secondhand smoke because they say that they've heard it all before. However, they usually are quite stopped in their tracks when I mention third-hand smoke to them, because when I mention that children in our own hospital who had parents who didn't smoke anywhere around their child still had high levels of third-hand smoke on their hands, then they pretty much are left speechless. I also tell them sometimes what I call the bacon analogy, which I believe I first heard from Karen Wilson. And this reflects back on what Georg said at the beginning about secondhand smoke. So what I tell them is that I say, well, imagine that you had a house with 3 stories and you had a kitchen and a far room in the basement, and you cooked some bacon. Do you think that the smell of that bacon would emanate and go up to a far room on the 3rd floor of your house? And they all say, oh yeah, of course. So if they can relate to that, I say, well, that's the same with secondhand smoke. It pervades every space that it possibly can and will reach every part of your home. So there really is no safe level. And from there, I discuss with them the effects that third-hand smoke can also cause. So in summary, I would recommend that clinicians use the 5 A's to routinely incorporate third-hand smoke messaging into the advised step. They should explain that third-hand smoke exposure is associated with concerning health effects. So they need to quit not only for their health, but for the health of their children and for the health of family members as well, because it is affecting the whole family. It is important to emphasize that there is no safe level of exposure, so stopping all tobacco or nicotine products is the goal. They need to enforce strict rules of no tobacco use, and strict smoking bans must be implemented. And they also need to be aware that smoking bans do not eliminate exposure completely. And I'm happy to take questions at this time.
Thank you so much, Dr. Gittens. I have a couple questions that have come in. One question that we had earlier on that I think applies to you is how we determine if exposure from third-hand smoke has come from dermal intake or inhalation, and what type of testing is required to determine this, since urine samples may have limitations. Are we taking dermal samples, or how are we measuring this?
So yes, so dermal samples would be where we have gotten hand nicotine levels from children. So yes, you can take dermal samples. At this time, they need to be processed in a special lab. We send them to San Diego State University to get processed and analyzed for nicotine. The difficulty is that it is very, very hard to know if the exposure is coming from secondhand or third-hand smoke. So you can get combinations because there is no specific biomarker to tell for sure this is only coming from third-hand smoke. So we are currently actually just enrolling in a study that got halted with COVID, and hopefully we'll be starting back soon, to look at children who are exposed to third-hand smoke only. And the way that we will do that is to assess levels of third-hand smoke that indicate that they've been exposed to third-hand smoke, but very low levels of cotinine that show that they have not been exposed to secondhand smoke as well.
All right, thank you. And one more question. This one was, what advice would you have for those who are going out to schools or teaching children about this topic? And I would think this also applies to a clinical setting. How do you speak with children when they cannot control what the adults are doing in their living environment?
That's an excellent question. I wish I had a great answer for that. However, what I will say is that for children can be very powerful influences on on their parents. And talking to parents about this may really push parents in the positive direction to try to quit, or at the very least to implement very, very strict policies where they never have any smoking in the home. Fortunately, most public places now do have bans, so this is becoming less of an issue. Beyond that, there's not a whole lot that I feel like children can necessarily do.
Great. Thank you so much for your presentation. There's a couple more questions that I'm going to, again, kind of delay for our general discussion and for some other speakers to address. So we're going to move on. And I'm going to introduce our third and final speaker today, who is Dr. Thomas Northrup. Dr. Northrup is an associate professor and the coordinator of behavioral science training in the Department of Family and Community Medicine at the University of Texas Health Science Center at Houston McGovern Medical School. Dr. Northrup's primary research interest is in the prevention of environmental tobacco smoke exposure for infants admitted to a neonatal intensive care unit, especially infants who may be discharged to homes where individuals smoke or vape. So thank you so much for joining us, Dr. Northrup. You may begin.
Wonderful. Well, I'm excited to have this opportunity to talk to you all about third-hand smoke and the environment of care. Next slide. So the environment of care, as we all know, is any site where patients are treated, and our goal is always to provide safe and effective care in this environment. But third-hand smoke contaminants pose a challenge because our cleaning protocols were not necessarily designed with third-hand smoke contaminants in mind. And we know that many patients and staff may smoke or vape and use other forms of tobacco and then come to these environments. And we take care of some highly vulnerable patients within hospital settings like ICUs. And I'm going to talk a lot about the neonatal ICU in particular, which I'll call the NICU throughout this presentation. And I encourage you to think of a rather extreme example of an infant born extremely premature, weighing under 2 pounds, who might be recovering from necrotizing enterocolitis surgery. Is it safe for that child to be exposed to third-hand smoke while they're recovering in the NICU? Next slide. And so I want to go over briefly some of the things I'll try to cover today, which are medical staff and patient and family smoking, some limitations of EOCs, the abbreviation I'll use for environments of care, as well as restrictions or bans, and then how to talk to colleagues and policymakers about third-hand smoke in the EOC. Next slide. So let's dive right in, first of all, to talking about medical staff smoking and third-hand smoke in the EOC. Next slide, please. So I love this graph. These data are from 2006-2007, which was one of the better large nationally representative studies of medical professional smoking, and I haven't seen a better one since that time. But the red dashed line at the top represents that in the US, 19.8% of the population was smoking in around Sorry, I got to move my part of my presentation there. Okay, in 2007. And you can see that respiratory therapists were pretty close to the US average at that time. And then as we move down from dental hygienists across PAs all the way to physicians, it falls to 2.3%. And in 2018, the US smoking rate is around 13.7%. So undoubtedly, levels of smoking in medical professionals has fallen since that time. Next slide, please. But one thing I'm very interested in is the proportion of medical staff who may live with individuals who smoke or use electronic nicotine devices and then come into the clinics and hospitals. You can see in this cartoon here from 1908 that this wife is asking her husband to go smoke in the tool shed, possibly out of fear for third-hand smoke exposure. Next slide, please. So one study that we did up in the NICU was trying to characterize medical staff contributions to third-hand smoke, and we approached all medical staff while they were in daily staffings, and we asked them to do a brief one-page survey, and we randomly selected about a third of them to have a finger wiped for nicotine. Next slide, please. Just a brief note on methodology. If you're not familiar with finger and furniture nicotine wipes, what we do is we douse a cotton round with a solution of distilled water and 1% ascorbic acid, which is just vitamin C, and then we wipe the finger or the standardized area on the furniture very thoroughly. And we also use what are called blanks, which we can prepare in the same way as the wipe that we use to analyze the finger and the furniture. We will assay both of those wipes, and we can subtract the blank from the actual finger or furniture nicotine wipe, and that kind of gives us a net accounting of how much nicotine was on the finger or furniture. Next slide, please. And so what we found is that medical staff tended to participate at high levels. There were very few refusals. Most of the staff who participated were nurses. And Heather, you may want to advance. I think there's a couple of boxes, yeah, that populate here. So most of the staff were nurses, followed by respiratory therapists and physicians. We had very few current smokers or e-cigarette users, but we did have a relatively high proportion of staff who reported living with smokers or e-cigarette users. Next slide, please. And what we found is that the median finger nicotine level of staff was 0.232 nanograms per wipe. And just a reminder that a nanogram is a billionth of a gram. And so there are a couple animations here you may want to advance, Heather. What surprised us the most about this study was that 78% of medical staff had quantifiable finger nicotine levels. And I just want to remind you that this is after adjusting them for blanks, which account for nicotine already present in the sampling material and present in the ambient environment. Next slide, please. Just want to mention briefly that these data are published, as the next slide will show, and we can zip right past that in a second. But as you might expect, staff who reported being near smoking in friends and family members' homes, of which about a third of the sample reported, tended to have higher levels of finger nicotine. Overall, nearly 3/4 of medical staff reported exposure to smoke in other locations outside of friends and family members' homes, and about half the sample reported exposure to vaping in other settings. Next slide, please. This is just the slide listing the publication in tobacco-induced diseases if you wish to read more. Next slide. Now let's talk a little bit about patient and family smoking and third-hand smoke in the environment of care. Next slide, please. So as I mentioned before, smoking has hit an all-time low in 2018 at around 13.7%, but there's lots of vaping and use of multiple products. In fact, about 18.8% of the US is using 2 or more products, 19.7% are using at least some form of tobacco, and we know vaping is extremely common with teens and young adults, with over 1/4 of them reporting e-cigarette use during high school. Next slide, please. So in primary care clinics, where many of you are, We've long known that smokers tend to have more medical and dental health needs, and there's some work, there's a citation listed here by Fiore et al. Showing that up to 70% of individuals who smoke see a physician annually. And we know that 7.7% of adults reported e-cigarette in the past use in primary care settings. And that study is a little dated now and may be even higher. And so we know that there is ample opportunity to treat tobacco dependence in this setting. For those of you who work with pregnant women or practice in OB/GYN clinics, national surveys recently have shown that a surprisingly high level of women still smoke during pregnancy. At about 5.6% report using only cigarettes, 6.5% use only e-cigarettes, and then 8.5% may use some combination of them throughout their pregnancy. And the bottom bullet here is a study that I did in an urban prenatal clinic in Houston, where we surveyed women who live with one or more smokers and found that about 55% of them cannot or do not ban smoking in their homes, raising substantial risk for secondhand and third-hand smoke exposure. Next slide, please. Most of my work is done through the hospital NICU. And we have documented over the course of a decade that about a quarter of infants in our Houston NICU are going to be discharged to a home where at least one smoker resides. And this doesn't account for rising trends in e-cigarette or vaping exposure and potential underreporting in this setting. We also know that about 3/4 of these infants are going to be visited during their hospitalization by at least one member of their home who smokes. Next slide, please. And so with this in mind, let's start talking about some limitations of the EOC's smoking restrictions and bans. Next slide, please. So pre-COVID-19, studies showed that only about 40% of ICU medical staff consistently wash their hands, which poses a problem for potential dermal transmission. We also know that many individuals who smoke or vape do so very close to clinic or hospital entrances, then they extinguish those cigarettes or stop vaping and immediately walk indoors. Well, particulate matter is going to be expelled on their breath for about 1.5 minutes. We know that benzene and other neurotoxic fumes are going to emit for even longer. And there was a fascinating study out of Spain about a decade ago where they tried to look at airborne nicotine in hospitals before and after a national smoking ban went into effect. And you could still measure it even after the smoking ban went into effect in terms of 0.1 micrograms, which is equivalent to 1,000 nanograms. And it was predominantly measured near entrances, fire exits, cafeterias, and ED waiting areas. But from Georg's talk, we know that those contaminants are going to drift and waft throughout the hospital setting, potentially exposing patients. Again, from my own work in the NICU, we found that only 30% of NICU parents always wear gowns, and 15% of parents report sometimes wearing gloves, raising potential for exposure from third-hand smoke residue on clothing and hands. Next slide, please. If you haven't been in a NICU in a while, just want to orient you to the fact that there are both shared pods with up to 8 incubators, and there are individual rooms which might have an open-air crib, a chair, and a couch. Next slide, please. So I'm going to present 3 phases of research that we did recently with non-staff visitors to our NICU. So these were predominantly parents, but we recruited anyone who was visiting an infant bedside, so it could be grandma, grandpa, aunt, uncle. We did an interview and a finger nicotine wipe with them, as well as a carbon monoxide breath sample. And we found that about 21.4% of the visitors in the NICU reported living in tobacco-using homes. So these could be smoking and ENDS using homes. END stands for electronic nicotine devices. But we also had a few smokeless tobacco-only homes. It's important to understand that people who use smokeless tobacco are still going to have nicotine and other third-hand smoke contaminant, not third-hand smoke necessarily, but they're going to have residual nicotine and tobacco contaminants on their fingers. Next slide, please. So what we found from this phase was that nearly 2/3 of the parents visiting an infant in the NICU had quantifiable finger nicotine, which greatly exceeded our hypothesis. And you can see here from this table that individuals from tobacco-using homes had significantly greater levels of nicotine on their fingers. And these are expressed in nanograms per finger. Next slide, please. We did some regression analyses to try to understand who was most likely to have lower finger nicotine levels, and these won't be surprising to most of you, that individuals from non-tobacco using homes, individuals who abstain from tobacco, individuals who use gloves, and some hand washing and sanitization practices, as well as a few other participant characteristics correlated with lower finger nicotine levels. And we hope to have these data published with the next two phases very soon. Next slide, please. So now I want to talk about a dyad phase that only involved mothers and infants. And really the only thing we added to this phase above and beyond the others is that we collected a urine sample from infants while they were in the NICU, and we took a furniture sample from the NICU room where the infant was staying. We recruited 80 infant mother dyads overall, but we over-recruited individuals from tobacco using homes at a rate of about 3 to 1. And I just want to remind the listeners that there's no secondhand smoke exposure in this environment. This is all third-hand smoke exposure within the NICU. Next slide, please. Our furniture data demonstrated that infants from non-tobacco using homes had 25.7% lower furniture nicotine levels compared to infants from tobacco using homes. But the surprising thing for us was, again, that regardless of home type, about 94% of infants' rooms had furniture nicotine that was detected during our wipe procedure. Next slide. And what may shock many of you even more is that infants from non-tobacco using homes may have had cotinine levels. Cotinine is, again, the metabolite of nicotine, the primary metabolite of nicotine. They had levels that were 71.7% lower than the urine cotinine levels from infants from tobacco using homes, but regardless of home type, once again, 94% of infants had urine cotinine detected in their sample. And when we ran our regressions, we found that greater use of and exposure to tobacco or nicotine correlated with greater furniture nicotine and urine cotinine, as you might expect. Next slide, please. Lastly, I want to share the results of a small hand washing and sanitization study that we conducted with individuals who reported being a current smoker and having a carbon monoxide breath level of 7 parts per million or greater. Next slide. We would randomize people to either hand washing or sanitization, and the way it worked is we would wipe either a thumb, index, or middle finger, and the order of fingers was randomized as well. So we would wipe finger 1, then we would have them wash or sanitize for 30 seconds. We would wait 5 minutes to allow for some air drying and wipe a second finger, and then after an interview 40 to 60 minutes later, we would wipe the third finger. Next slide, please. And what you can see here from the graph on the left is that hand washing participants tended to have a pretty dramatic decline in finger nicotine levels from finger 1 to finger 2. But you see this kind of steady rebound from finger 2 to finger 3 of nicotine sweating back to the surface. Whereas on the right-hand graph for the sanitization participants, you see very flat lines and even some lines that tended to creep upward as time went on. Next slide. So I've also provided a table here with some measures of central tendency, and there are 3 boxes that'll pop up, Heather, if you want to populate those. These are the geometric means, which really tell the tale that even in the hand washing condition, nicotine declined from finger 1 to finger 2, but it was not completely removed. And so infants who are being held by individuals even after rigorous hand washing may likely be exposed through dermal routes to the nicotine on their caregiver's hands. Next slide, please. So I want to wrap up by talking about some ways you can address this with colleagues and policymakers, and I'm going to underscore a lot of what Melinda and Georg have already gone through. Next slide, please. So it's important, first of all, to stress to our colleagues that third-hand smoke-related harm is evident at this point. We know it causes DNA damage. I'm doing some work which I hope to publish very soon with a neonatology fellow who is demonstrating that in utero exposure to nicotine, which I determine or I think of as third-hand smoke exposure, can raise risks for hypoglycemia at birth. And that's even after accounting for normal risk factors for hypoglycemia, such as being small for gestational age or intrauterine growth restriction. We're also doing some work, and I know Georg's group is doing some work in this area too, on microbiome differences across homes and children that are exposed to tobacco contaminants. And we're finding some very interesting things, which we hope to have in print very soon. We want to underscore to policymakers and colleagues that hand washing is only partially effective. It results in incomplete removal, and sanitizer may not be effective at all. There's also this sweating rebound that we've shown in this very small study, to be honest, but it looks like nicotine embedded in the deeper levels of the epidermis is going to come back to the surface, similar to what Georg was talking about in furniture and wall reservoirs earlier in the presentation. Next slide, please. And so transmission has many routes. We've hit this point on the head, but one more study I will share with you relates to breast milk, and that infants of mothers who do not smoke but live with smokers or e-cigarette users have nicotine or cotinine levels that are still 7 times greater than infants of mothers from non-tobacco using households. And this manuscript is under review currently. Finally, we must address all sources of tobacco exposure to mitigate third-hand smoke in the EOC. So on the next slide, you can see 2 studies that we've published for how we think about trying to reduce tobacco exposure for infants in the neonatal ICU. On the right-hand side, we try to deliver nicotine replacement therapy and smoking cessation resources to all members of the household. Next slide, please. So the important place to start is by screening and treating all visitors with these evidence-based NRT and other treatments. We know that about 22% of patients who visit a primary care provider were identified as smokers via screening. So screening is effective. And we know that this is a highly opportunistic population, and we can't miss this chance to intervene by encouraging a culture of asking about tobacco use non-judgmentally and employing those 5 A's strategies that Melinda highlighted before, and other strategies like motivational interviewing. So on the last slide here, I provided some additional resources to include with the ones Melinda provided before if you want to read up more on providing NRT and other smoking or tobacco cessation treatments to your patients. And it's a timely message to promote hand washing to reduce both infection and third-hand smoke transmission. And I'm happy to take a few questions before Georg, Melinda, and I get into busting a few myths.
Great, thank you so much. So we have a couple questions. A few of them address the pathways through which babies are contaminated by secondhand or thirdhand smoke. So, for example, whether it enters dermally or orally, and you just concluded with a discussion around breast milk, but do we have ways of determining whether the exposure has been through dermal absorption or inhalation, and how do we kind of figure that out and measure it?
Yeah, so Georg might know the reference, or Melinda too, but there was a fascinating study published recently where they put a hood over adult participants, and I think they gave them access to a clean or protected air source while they were wearing t-shirts that were saturated with third-hand smoke contaminants. And so they protected the individual from breathing in third-hand smoke vapors. And so all of the exposure was dermal. And I don't remember all the findings from that, but the takeaway message is that a significant level of absorption occurred through the clothing. There's also been some estimates put out there for children who mouth furniture and toys and how much third-hand smoke exposure they take up through that route. Georg presented that study about being in a non-smoking movie theater a little earlier. And so as the lab scientists get more creative, I think we're going to see some more specific answers to this going forward. And Georg, you may have something to add to that, what your group's doing out in California.
Okay, I'm going to follow up with one more question, just a clarifying question that you indicated it seemed that non-smoking parents were participating in the spread of third-hand smoke toxicants. So is this what you are actually saying? And how is it that a non-smoking parent could be bringing a third-hand smoke into a NICU?
Sure, I think to some extent we're all unwittingly spreading and being contaminated by third-hand smoke contaminants all the time, just by way of touching doorknobs and coming in contact with it in environments where smokers visit. I think the study Georg shared on non-smoking movie theaters is a really good example. We all tend to enjoy going out in public spaces, and so exposure can occur there. But the medical staff study I shared demonstrated that individuals who go into friends and family members' homes who tend to smoke or use e-cigarettes are going to wind up with more contaminants on their clothing and bring that back to their own homes, even if they're non-smokers. Or if they're going directly from that environment to work on occasion, they're going to bring those contaminants with them on their shoes, on their pants, on their hair, on their skin. And so to some extent, I would agree with the questioner's frame there, that even individuals who do not smoke or use tobacco can unwittingly spread it, it being third-hand smoke.
Great, thank you. So we had a final question about the white recipe that you provided, and I'm going to ask that you maybe type that answer in and so that we can move on. And also, again, these slides and all of this content will be made available through an archive of the webinar, so you can access this information later. So we're going to move on to our Mythbusters section of this webinar. So I'm going to ask that all of our speakers turn on their video, and I'm going to kind of shoot these out to different speakers based on the questions. So these are common questions that we get at the Thirdhand Smoke Resource Center that we wanted to address with all of you. So the first myth is that if you can't smell THS, then it isn't a health risk. So I'm going to send this off to you, Georg. Is this true or false?
Very unfortunately, this is false. And there are two major reasons for it. Number one, we know that the odor experience is really a perception. It involves some volatile chemicals. Remember these VOCs floating through our noses by some olfactory receptors, and some send a signal to our brain and others don't. So some of the constituents of third-hand smoke are odorant, whereas others are odorless. So that's one important limitation here. Of course, we all differ in terms of our sensitivity to smell, and that's a big difference too. Another reason why this is false is because it is quite common in some fields, including private homes, but also hotels and restaurants and so forth, to try to cover up unpleasant odors. And in some cases, this involves, a spray. This, in other cases, involves something called odor eaters or air fresheners. And some of these strategies are actually rather harmful. Number one, because they spray fine and ultrafine particles into the air that can be harmful. But even more importantly, that some of these strategies involve secondary chemical reactions. It involves emitting oxidants into the air that cause a chemical reaction that turns odorant compounds into odorless compounds. And some of these odorless compounds may be more hazardous than the odorant compounds. So if you ever come across an ozone machine or a hydroxyl machine that claims to destroy tobacco smoke, it does not. It creates a chemical reaction that creates odorless compounds, but it may create additional fine and ultrafine particles, and it may generate odorless, rather toxic compounds instead.
Great. Okay, let's move on to our next one. So the problem with THS is really its unpleasant odor. Do you want to continue with that conversation just a little bit more, Georg?
Yes.
And there was one specific question earlier which discussed whether or not the filtration of secondhand smoke could eliminate third-hand smoke. So perhaps you could include that in your response to this myth.
Right. So as I just pointed out, odor is really an experience. It's a human experience. Now, almost universally, stale tobacco smoke is experienced as unpleasant by smokers as well as non-smokers. But the experience itself is a function of a threshold that may differ from person to person. And of course, as we just discussed, there are some compounds that are odorless that may be even more harmful. Now, as I discussed earlier, tobacco smoke consists of fine and ultrafine particles as well as volatile gases. Air filtration systems do not remove volatile gases. They filter out particulate matter. Now, they do not filter out all particulate matter, but they filter out with a certain efficiency particles of a certain size. Now, as you remember, perhaps from one of the slides, the median diameter of secondhand smoke and third-hand smoke is in the range of 0.2 or smaller micrometers of these particles. Now, in order to filter out such particles that are smaller, one needs machines that are not really available commercially. So these are ultrafine particles that go through a filtration system. And of course, the volatile compounds are not trapped or filtered out by air filtration systems at all. For that, one needs to have activated carbon filtration system, and that's typically not available to regular consumers.
Perfect. Thank you. All right. So another, unfortunately, somewhat common kind of statement that we've received is that the risk from third-hand smoke is no worse than spilled coffee or the like. So I'm going to send this over to you, Thomas. What is your response? True, false, or partially true?
Okay, are we going off script? I think that one was for Georg.
Sorry. Actually, I think it was for Melinda.
Oh, was it Melinda? Okay.
Melinda. I went off script. Sorry about that.
Yeah, so So of course, after all that we've talked about, this is definitely false. And that's because the mixture of chemicals in third-hand smoke includes potent carcinogens, developmental toxicants, irritants, asthma triggers, and other hazardous chemicals. So if exposure is infrequent, like you can liken that to a sunburn, for example, the impact can be very different than chronic exposure that you would see if you have so if you're likening it to sunburn, which happens infrequently, that can lead to skin cancer if you have long-term chronic exposure. And of course, we know that third-hand smoke involves chronic exposure to these toxicants, which can, of course, be hazardous to human health. So false for sure.
All right, thank you. And I've got one more for you, Melinda, while you're at it. So another one is a follow a don't ask, don't tell approach. As long as we don't talk about it and don't mention it, then it's not really a problem.
So this is definitely false also, because as we've just learned, third-hand smoke is lurking and is pretty ubiquitous, unfortunately, in many, many places. It is important to ask about previous tobacco use to avoid third-hand smoke exposure. Apartment managers, used car salespeople, hotel managers, real estate agents, they sometimes actually don't know if there is third-hand smoke because they don't know if former owners were smokers. But other times they intentionally might not give that information out, hoping that we won't ask about it or they might claim ignorance. So it is important to ask about previous tobacco use before buying or renting to avoid third-hand smoke exposure.
Great, and I've seen a few questions on our chat and Q&A about how to inquire and to address the issue of third-hand smoke when buying a home or a car. And we have a lot of resources on the Thirdhand Smoke Resource Center website, which is, again, www.thirdhandsmoke.org, about this exact topic. In fact, our question of the week this week addresses how to ask questions and inquire about third-hand smoke when buying a used car. So I encourage, again, all of you to go check out those resources on the website. So, okay, Thomas, I'm coming to you now. Over time, the risk will go away.
Yeah, so this is a myth that the four of us had an interesting discussion about yesterday, and actually changed the answer to be partially correct because we wanted to end on a somewhat hopeful note. You know, it really depends on the degree of smoking in the environment or vaping, the depth of some of the reservoirs to which these third-hand smoke contaminants are depositing. I think Georg talked about this earlier, that drywall looks like a smooth surface to most of us, but it's porous. It's got a lot of small, tiny holes in it, and we're talking about microns and things much smaller than microns. They're going to fill it up. And so if smoking stops in an environment and the cleaning protocols are rigorous and relatively frequent, then over time it will begin to dissipate. Even though that odor may go away quickly, we know that these compounds are going to persist, and it can take significant remediation to completely rid an environment of these toxicants. And we hope to have more specific guidance for people as studies continue to accrue in this area.
Great, and along those same lines, and we've had a number of questions about this topic as well in terms of mitigation and what can we do to make our housing healthier. But can you remove third-hand smoke by painting and replacing carpet?
Yeah, and so this is partially correct. You're not going to remove it, but Georg assures me that you can slow the off-gassing process by painting over third-hand smoke residue on walls and potentially keep less of it from emitting in your home. And then if you remove furniture and carpets and things like that, that's going to partially remediate that environment. But the thing we always want to underscore to our patients and anyone we're speaking to about third-hand smoke is the best thing we can do is completely prevent exposure in the first place. And I know I'm talking at 99 members of the choir here, and this can be challenging with our patients, but it really is our best practice to try to remind people that the only way to completely eliminate third-hand smoke in an environment is to ensure that no active smoking occurs there, and that we're not tracking in these contaminants and making that environment polluted going forward.
Terrific. We have really just a few minutes left. I was wondering, Georg, if you wanted to add anything about any resources that are available for people. You mentioned kind of avoiding ozone, but are there some best practices that you would recommend for how to clean in less than 1 minute?
So what Tom mentioned is really important. Cleaning and the success of cleaning is really a function of the type and the depth of reservoir. So it's important to understand what in my home or what in my office or what in my work environment is polluted. Is it a couch that I brought in from a friend? Is it the carpeting that has not been replaced over several generations of tenants? Or is it an apartment where somebody, as we've studied recently, where somebody lived in for 20 years and smoked a pack of cigarettes a day? If that's the case, then there's only the solution of remodeling, replacing, gutting an apartment, and rebuilding.
All right, thank you. And so I just want to close this hour and a half of really engaging and informative talks by our speakers. I want to thank our speakers again, Drs. Matt, Drs. Mahabee-Gittens, and Dr. Northrup for their excellent talks. I want to thank the Thirdhand Smoke Resource Center staff for all of their hard work over the last several months to prepare for this webinar and for their constant work related to the topic. And again, check out all of our social media and website. I'm going to provide those links in just 1 second. I want to thank the Thirdhand Smoke Resource Consortium researchers and the associated investigators, as well as the Tobacco-Related Disease Research Program for our support. And again, thank all of you for joining and caring about this topic and protecting, especially our young children, from this exposure. Again, I want you to follow us. Please, if you can, follow us on Facebook at Thirdhand Smoke Resource Center, Instagram at THS Resources, and Twitter at THS Resources. And again, we have all of these issues addressed on our website at www.thirdhandsmoke.org. So thank you all again. We will be sending out a link to this recording quickly, and you can always find it archived on the website. Thank you again for all of your time and your participation, and we look forward to our next webinar and hope you will join.